Good evening. I'm Dr. Mauricio Gonzalez. I'm a triple board certified physician practicing in the most beautiful city in the world, New York City, and I specialize in health communications, especially for the Hispanic community. And my 7-year-old always says, "Dad, why do you say health communications? Just say that you're social media famous." We're talking about something that is vital to the survival in the medical industry, but we don't talk about it enough. We're going to talk about the social science of clinical science and how accurate is this title. There's always a social component to clinical care. Always. Hey, Mr. Smith, you got to take this medication for your blood pressure. See you in 3 months. But inside that little head of Mr. Smith is how many times per day? What's going to happen to my legs? Is it safe for my heart? Can I eat anything with this medication? So this gap of understanding, of medical understanding in our communities create a massive, massive gap that drives inequality and reduces good outcomes. So hopefully today with our panel, we will be able to, I want to say something before we move on. So far, the vibe that I gotten here is energy and commitment. Let's not get that fade away. And hopefully this panel will bring valuable insights and perspectives about the social science of clinical science. With that, I welcome our two phenomenal panelists. Let's start with Dr. Juliet Nevins. Welcome, please. Medical Director of CVS and Aetna. And we also have with us John Vu, which is the Vice President of Community Health, yes, in Kaiser Permanente. Please, be seated. Okay, so obviously, and completely central to what we have been discussing, we're going to start with social determinants of health. And I'm going to speak from a physician perspective. Social determinants of health in the past used to be a thing that we knew it mattered, we just didn't know how much. Now we have excellent clinical studies highlighting the impact of social determinants of health on things like cardiovascular diseases, diabetes, obesity, metabolic syndrome. And one of my favorite studies in the literature describes that studying social determinants of health is basically studying the biology of adversity. And I truly found it fascinating. So why don't we jump right in? Dr. Nevins, can we start with you? Can you share any specific success stories or examples within your organization where focusing on social determinants of health has significantly improved patient outcomes?
Absolutely. First, thank you, and it's a pleasure to be here. And this is such an important discussion, and I'm so happy that I'm in this wonderful company of thought leaders. I should mention, by the way, that my major in college was human biology and its social context.
Wow.
So I won't tell you, how many years ago that was, but here I am.
Recently.
So, exactly. So it's a very important thing. So social determinants of health, what does that mean, right? We've been talking about it. We've mentioned housing, food deserts, jobs, education, health literacy, right, which includes understanding how to interact with the healthcare provider in a virtual platform, as we can, as we saw during COVID, was a major problem, right? Health literacy around nutrition, as was mentioned before. So these are areas with the variables around the cause are vast. They stem from the individual to the provider to the institution. And so it is a daunting task to sort of attack all of this holistically. but we can break it up in small little pieces. So part of my role at CVS is to review healthcare utilization data. And we're now at the beginning of mapping social determinants of health. We have an algorithm that allows us to assess or assign risk factors to certain zip codes. And then we give this to the employer, right? And that allows them to design their benefits, choose wellness programs, for example, that will target certain zip codes. And so there is maturity that we're hoping to gain from doing this in this manner. In 10 years from now, we want to be able to understand which neighborhoods still have a lot of people using the emergency room, for example, in lieu of going to the primary care data. So collecting the data, using it to design our policies and our wellness programs, giving it to the hospitals to help them with the value-based contracts, right? You know, so with the data, you know, we collect the data, we have it. We can use it to design and color interventions in the hospital, you know, and certainly with respect to private employers.
That would certainly be very impactful, because without the data, we're just doing efforts without knowing whether they're going to succeed or not. So you can tailor treatments or preventive strategies for different conditions in different zip codes. Fascinated. Mm-hmm. John, as a vice president of community health in Kaiser Permanente, I'm sure the word social determinants of health is pretty much every day on your desk, right? Yeah. Can you share some success stories within your organization addressing the social determinants of health?
Yeah, of course. And thank you for this opportunity. I think first thing I'll say is, for those outside the US, the Kaiser Permanente, we're an integrated healthcare delivery system from the insurance all the way through the care delivery model. So there was talk earlier about the world needs to integrate the healthcare system, and we've been that design since the beginning. And what that does is incentivizes us, people were talking about incentives earlier, to keep people healthy. We don't get paid more for doing yet another surgery, or doing, you know, if we botch one procedure, we're gonna do it again and we'll get paid again. So I think moving to a model like that, the magic wand solution people were talking about earlier. And given that model, we are incentivized to kind of keep people healthy. And as you were saying, as social determinant science got more and more sophisticated, we realized, how do we embrace that? We provide medical care and coverage, but if health is all these other things, what are we going to do as a hospital and clinic system? What's our rightful place in addressing housing and addressing food insecurity, transportation issues? So one of the big, so about 4 or 5 years ago, we said, how do we systematically build that into care protocols? How do we make that just part of the fabric of taking care? How do we integrate that into the medical record system so that it becomes, you know, your blood pressure, your weight, your mammography record, and that you are facing eviction issues, and that you're facing budget problems right now to cover your food? So then, how do you identify those things? So we've now built at scale an ability. This year, we're going to be able to screen 3 million of our 13 million members that we have, 3 million screens of people who may face these social health risk issues. And then we've created a system to point them to resources to address those issues. All these things around addressing food, housing, legal aid exist in the community. So now we can like almost like a prescription, point them to these things in a sort of a two-way referral system. So it's not just sort of, here's the number to the food bank, or here's, call this lawyer, he might be able to help you with your landlord, but it's actually pointing to a credible, vetted, like legal aid group or the food bank. And then we get information back about, so Mrs. Jones did come and get this legal aid, and now it's part of the medical record in that way. So you talk about data, I mean, that's going to create a whole system of data that we've never sort of imagined before. And we want to get to the point where a little bit a ways off still, though, to get to sort of predictive analytics. We have all this information, and zip code is a huge predictor. We know where people live, their addresses, and we know all these other issues about them medically. We could easily start combining that and saying, you know, what if we do a proactive reach to address, like, we think these people may be facing some food insecurity. We launched a texting campaign 2 years ago to say, if you're facing some food insecurity issues and affording food every month, did you know there are SNAP benefits? And it was easy, accessible, and if you do, did you know you can enroll this way? Piece by piece, they were engaging instead of like just getting a flood of information, facing a huge government bureaucracy and trying to figure that out and just sort of giving up. These were like ways to do that. So I think just doing that, and the good news is I think a lot of health systems, at least in the United States, are starting to think about how they operationalize something like this and address systematically, again, social needs across people. And again, these kinds of social needs fall disproportionately on people of color, low-income people, people on Medicaid. So it's closing huge gaps. And what we're starting to find is that it builds a trust. Like I'm gonna come to you, but you're also working on these other things and you reliably are addressing it, I'm gonna trust you for all other sorts of information and to take care of, and you're thinking about me holistically as a whole person that way.
Mm-hmm.
Exactly. It's actually fascinating how Kaiser Permanente has always been at the forefront of addressing these issues. And I know one of my favorite studies is that in some clinics in Kaiser Permanente system, they implemented another vital sign, physical activity. You go to a hospital and they check your blood pressure, heart rate, oxygen saturation, okay, they check your BMI, whatever. They never document physical activity. Kaiser Permanente has been doing this, gathering data, and they already showed that people with high physical activity index had less complications from COVID, less CVD. So data is incredibly important, and when it's linked to social determinants of health, the outcomes are much, much better. Now, let's talk about a rocky topic. Mm-hmm. Okay. Patient-centered care. Mm-hmm. Most of the work that I do in health communications is through social media. Social media is good and bad. It's bad for the reasons that you know. Mm-hmm. It's good from the fact that it's a bi-directional conversation. I say something, and then I listen. I read. So you gather the temperature of the people that follow you. And in the United States, there's this talk constant that healthcare is profit-driven. And we know, everybody here know that profit is a good thing because it incentivizes research programs. It creates a whole of good things. Now, healthcare is definitely profit-centered. But my question to you both is, can it also be patient-centered? Dr. Nevins, can you share any strategies or initiatives that your organization has done to make sure patient voices are heard?
Absolutely, and I'm going to start, my preamble is this, that you cannot have profit if your patients are unhealthy, right? And to move towards healthy patients, you need patient-centered care. You need health literacy. I'm very big on that. You need health literacy that lends to shared decision-making. So, there are two things that we do in CVS, and that's we really put a lot of resources into training our case managers and disease managers. The next step is to make sure there's parity between race, ethnicity, and language, right? So that when you go into these communities and when you're trying to connect with these members, that there is a reciprocity in terms of trust and understanding. That is very, very crucial. So we believe that using these ancillary services, physicians alone cannot do it. The system needs to be very, very holistic. And I'll give you a personal example as a physician, as an OBGYN, a feminist, I would even declare that I was asked to collect data on domestic violence and I did not want to do it. Why? What if she says yes? Then what? I have no resources. Yeah. There's nothing in the computer that I'm going to print out and give to her. We don't have case managers, there's no one here, right? So The data is important, but what comes out, what you do with it, is also essential. So I think this is where those community ambassadors come into play in terms of nutritionists, case managers, and disease managers, for example. The other thing is, the brick and mortar buildings that serve as a bridge, if you will, between the patient and the primary care doctor. At CVS, 80% of our members live within 10 miles of a brick and mortar store. And I use those pharmacists. They give me my vaccine.
Yeah.
I go there, or I can if I need to have my blood pressure checked. So it does not necessarily lend to more fracturing of the system, I believe, but it does plug holes, especially if you have a system where you are creating continuity by making sure that your medical records are connecting to the primary care doctor. So those are two fundamental things. Access to care by way of the brick and mortar, by way of all the virtual programs that we have built into our system and available to our members, and certainly a plethora, a host, an army of case managers, disease managers that are there to sort of tackle these problems and help these members navigate the health system by helping them understand and mitigate the impact of whatever particular social determinant is thwarting and preventing them from moving towards health.
Perfect. John, Kaiser Permanente has this identity where people from the outside think is self-sustainable because of the entire insurance, hospital delivery, or care delivery system that you have. And I'm sure you have to discuss the diversity within your patient population. So can you share some success stories within your organization where you created initiatives to make sure patient voices are heard?
Yep. And just for the record, we are a not-for-profit, mission-driven organization. And I think, though, that profits and good health can exist together despite that. But we believe, since our founding, we've been a not-for-profit with that mission-driven. We're still a $105 billion company. And you have to, there's an old saying in not-for-profit, especially Catholic healthcare, no mission, no margin, and no margin, no mission. So you got to make some money because it's capital heavy, it's capital intensive. So for us, I think part of what I described earlier about the social health, we surveyed 10,000 of our members 2 years ago to ask them, are you facing any of these social health issues? 63% of them, 2/3 said, yeah, I'm facing either a financial issue right now, a job issue, whatever it is. We polled them again earlier this year. It's at 68% now who have said that. And the diversity of the people that we understand who we polled, we were able to segment it. We're able to slice and dice our data by race, ethnicity, language issues. We saw gaps in colorectal cancer screening for Latinos. We see cardiovascular disease differences for African American men. And then that's what healthcare does. They find a problem, they get the data behind it, and then they're laser focused in addressing those things. So we're starting to close those gaps and create so that there are no gaps, bend the whole curve for everybody, but close those gaps. So, there's been examples of that. Cultural competency, we found about 170 different languages across our patients and members. We try to hire and promote people in positions that reflect our community as best as possible, recruitment on all of that, hard to hire, and the whole host of other things to understand. I know our time is short.
That's perfect. That's actually very good. It's a lot. It's a lot of efforts, a lot of work. Now, since we're coming to an end, last question is, what is your wish? What exactly do you want this forum doing or executing? And you can ask. Think about it like Christmas. Ask whatever you want. So
I was hoping we would get the magic wand too. The last panelists, they all got it.
Well, we can do the magic wand as well.
My wish is that we as a physician, I think the hardest thing for me to watch, to experience, is that we operate in silos. And that has been said before, but in terms of the individual member, and when you're talking about social determinants of health, they need those other services, and those services need to be there, right? They should not leave. So I think we were talking before the beginning, New England Journal of Medicine, we had an article this month about population health, social determinants of health, that a lot of times we refer to community centers that are also less than optimally resourced, right? Yeah. So using those contracts, those value-based contracts, policy that someone else mentioned before, to make sure that we are approaching the patient as a team, so that when they leave, they have concrete steps to take to reach a status of health irrespective of whatever deficits they're facing. And I think that's what I would like to see, a team approach, and using technology, electronic medical records, AI, don't kill me. I said it. To really sort of approach the patient, from all sides, if you will.
I guess a lot of hopes and dreams for a forum like this, but I think a real macro view for me is there are a lot of coalitions out there already. There are a lot of experts working on health equity, and thinking about a global perspective, there are a lot of entities working on these issues. I want this one to be complementary to all of those. If I could wave a wand, they would find all the other doers that are doing stuff out there, and that we create a platform that actually houses success stories, actions, and a place for collaboration across the globe. The other thing is, the challenge is going to be, we've had a fairly US-centric discussion today, but as we look at health equity across the world, it's going to be tricky to balance certain issues. And I'd be remiss not to mention Climate Week, because we're here in the UN is, the Climate Week is happening coinciding with this, and climate is a major health equity issue. And in the US, we're trying to decarbonize, and I spend my days thinking a lot about, what are some carbon sequestration problems, and how do we fold renewable energy into affordable housing projects? Meanwhile, there's still issues like antimicrobial resistance around the world. Someone mentioned maternal mortality, but that's a huge, vast issue. So how are we going to balance health equity that ranges across so many countries, so different hemispheres, across issues that are completely sort of esoteric, like carbon sequestration, so to advance health, versus just basics like primary care access? So if I had a wand, this forum, this platform would be able to kind of meld all of that, be a coalition of coalitions, be a way to balance across a global perspective.
Well, thank you both for an incredibly insightful discussion. My invitation to this forum by Lily and Enrique, by the way, thank you so much for having me here. The invitation closed with a phrase that I loved: a journey towards a world where health equity is not just an aspiration, but a reality for all. So that's my wish. Thank you so much for being here.